Our lungs normally expand with every breath. But when air leaks into pleural cavity, that expansion stops. This is pneumothorax. It can occur spontaneously, that is in patient with pre-existing lung disease and or result from injury to chest wall. There are three types of pneumothorax: closed pneumothorax, open pneumothorax and life-threatening tension pneumothorax. In closed pneumothorax, air enters the pleural cavity but cannot escape. The leak seals up spontaneously and air moves out. Pressure does not rise progressively in this type of pneumothorax. The second one is open pneumothorax, sucking chest wound. There is free communication between pleural cavity and external air through a defect in chest wall. Air moves in and out with each respiration. And third one is tension pneumothorax, a life-threatening emergency in which air enters the pleural cavity on inspiration but cannot escape during expiration. This creates a positive intrathoracic pressure shifting the mediastinum, compressing a venous return and leading to shock. Diagnosis: chest X-ray shows sharply defined edge of the deflated lung with complete translucency. ABG analysis may be useful in evaluating hypoxia and hypercarbia and respiratory acidosis. The clinical findings: most common symptoms are sudden onset of unilateral pleuritic chest pain or breathlessness. A larger pneumothorax results in decreased or absent breath sounds. The combination of absent breath sounds and a resonant percussion note is the diagnostic of pneumothorax. By contrast, in tension pneumothorax, there is rapidly progressive breathlessness associated with marked tachycardia, tachypnea, hypotension and cyanosis. Management: if patient is asymptomatic, that is there is not breathlessness or anything and lung edge is less than 2 cm from the chest wall, it normally resolves without intervention. A watchful waiting with or without supplementation of oxygen is treatment for this. If there is moderate pneumothorax or large spontaneous pneumothorax, percutaneous needle aspiration of air or intercostal tube drainage is the treatment. Intercostal drain are inserted in 4th, 5th or 6th intercostal space in the mid-axillary line connected to underwater seal and secured firmly to the chest wall. The clamping of intercostal drain is potentially dangerous and rarely indicated. If the patient has a repeated episodes of pneumothorax or if the lung remains unexpanded after 5 days with the chest tube in situ, operative therapy is the choice. Here, short explanation on how to spot pneumothorax on chest X-ray. First, look for the sharp white line. That's the edge of collapsed lung. Beyond this line, you will see a completely black area. That's the air in the pleural space with no lung markings. On the affected site, breath sounds are absent and percussion is resonant. If it's tension pneumothorax, the X-ray will also show the mediastinum shifted to opposite side and the diaphragm pushed down. So remember, sharp lung edge plus no marking, pneumothorax, and if there's mediastinal shift, that's an emergency. So guys, this is all about pneumothorax.